how we can use this physiological information that EIT measures clinically to understand the disease and to personalize the respiratory support. And from the beginning of mechanical ventilation, control ventilation till the end, till the liberation of mechanical ventilation. I declare a conflict of interest with Temple Medical for this presentation. Okay, so let's start with a brief introduction. This is a simplified image summarizing how lung impedance change during a tidal ventilation. In this image, we have two electrodes. One is acting as an injector and the other as a receiver. And the red circle here in the center represents the alveoli wall. Note that at the end of expiration, to the end of inspiration, the alveoli wall become longer and thinner. And this makes much more difficult for the electrical current moving from one side to the other. And what the EIT measures is exactly this, is the change in voltage, the change in resistance when we have the tidal change in air content. And this is a graphical representation of this cycling oscillation in impedance during the respiratory breath. During the EIT examination, we have an alternating current that is applied through pairs of electrodes, while the remaining electrodes measures the resulting voltage. And one set of injection and measurements produce one EIT ventilation image. The advantage of this method is because we have high frequency data acquisition, allowing this dynamic monitoring of ventilation distribution. We can produce up to 50 images per second, and this is useful at the bedside to understand dynamic conditions. The image orientation is similar to that used by CT, with the right side located to the left side of the image and the anterior part of the image at the top of the image. And what about the interpretation of the ventilation image? Generally, the brightest pixels indicate an area with the highest electrical impedance variation. That means this pixel is the pixel with the highest change in ventilation. Conversely, the darker pixel indicate an area with lower variation in electrical impedance. And the waveforms on the right side can illustrate the difference in the amplitude of signal when we have the white pixel and the more darker pixel. And pixels in gray in this image represents areas without a change in impedance, such as bones and muscles. And if we consider inside the thoracic cavity, gray pixels may indicate that the lung is not ventilating, is not functioning as it should. And in this case, the absence of ventilation in the posterior right part of the lung may occur due to lung collapse, consolidation, or pleural effusion. So this image suggests the need for additional investigation for this patient. What are the ventilation distribution that we could expect in a patient with healthy lung? This is important because before seeing sick patients, we need to have on the back of our mind images collected from patients with healthy lungs, because this makes easy the identification of a true lung impairment in a sick patient. And this is what we have in average in a patient without lung disease. Patients with controlled ventilation and spontaneous breathing with normal lung may have effect of different variables changing the ventilation distribution. For instance, Patients under control ventilation may change the ventilation distribution due to PEEP change, tidal volume, and body positioning. Here we have one example of a patient with normal lung during abdominal surgery under anesthesia from PEEP to 20 to PEEP of 8, sorry. And what we can see here, we can see that the ventilation distribution at PEEP of 20 was about 30% in the ventral part, and we have 60% of ventilation in the dorsal part. Comparing with PEEP of 8, the ventilation distribution now changed, right? We have more ventilation in the ventral part of the lung. Now is about 50% ventral dorsal or anterior posterior regions. But clearly, we can see that the dorsal part, the anatomical dorsal part, looks similar. We don't have any reduction in pixels as a representation of alveolized units from PEEP of 20 to PEEP of 8. This means that this ventilation distribution changed in this healthy patient just because we reduce the amount of overdistension in the ventral part of the lung. At PEEP of 20, the overdistension was high in the ventral part, then the tidal volume changed, looking for areas with better compliance, right? So we need to pay attention on that, on combining the numbers of ventilation distribution and the shape, the quality of the image. In patients under spontaneous breathing, we know that the inspiratory effort makes a big change. In general, when we have a strong inspiratory effort, we shift the ventilation more to the dorsal part, more to the posterior or dependent part of the lung. And body positioning also makes a huge effect. But in general, for a patient without lung disease in supine position, this is the average. We have a slightly non-significant ventilation in the posterior part and a little bit on the right side as well, but both non-significant. In patients under spontaneous breathing, the body position makes a huge change. And in this case, we have a subject with high inspiratory effort and changing the body positioning, and we can see how different the ventilation distribution looks like. In supine, we have more ventilation in the dorsal part. When we change to the left side position, the lung that's close to the bedside ventilates more. When we shift it to the right side, the lung that's close to the bed ventilates more. And when we change to prone positioning, looks a little bit more homogeneous, the ventilation distribution. But this image shows clearly that we may consider the position that we are monitoring the patient to understand later what the image suggests to us. And just a brief explanation. This is what we are measuring is poor physiology, right? Is just physiology. Here I have my CT scan in lateral position with the bedside here close to this right lung. And in red, I'm illustrating my diaphragm. From the expiration to inspiration, we can see clearly that the right lung that's close to the bed is changing more the size, is increasing the size, is changing more ventilation. And this is exactly what the EIT measures. EIT measures the area that is moving more in terms of gas content. A short part of validations. This is the first validation studies in patients under control mechanical ventilation by Dr. Victorino. This paper was published in Blue Journal in 2004, 20 years ago. They use the Sheffield system with 16 electrodes. Here we have some examples of the regions of interest selected by CT and EIT. And one case representation. From the beginning of inspiration till the end of inspiration, using a low flow maneuver, we can see that only the left lung changed the gray the gray image, right? The shades of gray. So suggesting that we have only one lung ventilation, the right lung is not changing at all. And the EIT image agrees with the same rule, showing that only the left lung is being ventilated. And they found a good correlation, intra-patient correlation, showing that what EIT measures, the tidal change, is probably the change in air content with this R square of 0.92. Recently, we finished a validation study in patients under spontaneous breathing. This is under review. And we used the same approach using CT and EIT, dividing the lung in different regions of interest, as you can see here. And what we found, one interesting data we found was that the EIT image better represents a lung thickness close to 15 centimeters. This is a new information in our field. This graph shows the posterior region, the difference between EIT and CT to assess the ventilation in the posterior part of the lung. And in the x-axis, we have different slab thickness of the CT image. Look that if we consider the whole lung, we are going to underestimate the ventilation distribution. When we are close to 15 centimeters, we have a bias that's close to zero, and we increase our chance to measure something similar to the CT scan. The limits of agreement in this study was found close to 10% with a bias around zero for the posterior and anterior part of the lung and right and left part of the lung. And having this information, we were able to compare with other different validation studies using EIT with CT or different gold standard imaging method. And clearly, we can see some comparable numbers when we look at anterior, posterior, and right and left ROIs. For controlled ventilation and spontaneous breathing, we have similar numbers, about 10% of upper and lower limits of agreement. So after this brief summary of EIT performance in assessing ventilation, let's take a look at this image. Clearly, there is an imbalance in ventilation distribution between the right and the left lung, right? So knowing the validations that I show you, if we have an heterogeneity like this that is higher than 10 or 15% comparing the lungs, we can be sure that we have something affecting the lung of this patient. First, we need to be sure that the electrodes are well positioned, that we don't have any procedure effect on the image. Once we are 100% sure that the image acquisition has a good quality and we have this kind of image, okay, we are ready to further investigate this patient because probably there is something wrong. And that is the case. This patient has this huge pneumonia in the middle and posterior right lobe. And what are the clinical utilities of using this simple method, the ventilation image, to support the respiratory treatment? Why are we looking for that? Why we need this kind of information? So the answer is easy. It's because we need to personalize the respiratory support. We know that the population-based data do not necessarily reflect individual patients. Take, for example, ARDS, acute respiratory distress syndrome. This syndrome presents a wide range of clinical and pathological characteristics. We can easily imagine an ICU with ARDS patient where we have one patient with bilateral pneumonia, another with abdominal sepsis, another patient with more inflammation requiring pressors, other not well inflamed. So all this variability all these types of ARDS are not the same, we know, and we should not be treated those patients in the same way. And indeed, the literature demonstrates that relatively few randomized trials conducted in the ICU show a positive effect in survival. We have the majority of trials being negative trials, and we believe that there is something wrong with this. There are many possible explanations for this discouraging number of trials, and I like to quote Professor Brian Kavanagh, who was a great scientific critic who challenged evidence-based medicine. He argued that failure to match the proposed intervention with a potentially responsive patient dilutes any therapeutic effect. And if the intervention cannot plausibly help a given patient, it can only be neutral or harmful. And then the probable explanation for most of the false negative trials that we have is probably because we have a biological problem. We are not targeting the biological issue. This is not a statistical problem, it's a physiology and biological problem. And are personalized respiratory interventions a reality in critical care? Yes, personalized respiratory interventions are becoming increasingly feasible in critical care, and we are interested in that. For instance, this was a multicentric study from France, an interesting paper that the authors aimed to test a mechanical ventilation strategy that was personalized to the patient lung morphology. They used CT or chest X-ray to differentiate the patient with focal lung disease and non-focal lung disease. And in this trial, the treatment after randomization was based on that. For instance, in patients with the non-focal lung disease, they received as mandatory rule the lung recruitment, and they received more PEEP. In the other group, patients with focal lung disease, prone position was mandatory, and they used low PEEP and a little bit more tidal volume. And what this study, the authors found in this interesting paper, they found, unfortunately, a huge amount of misclassified patients. We know ARDS patients sometimes are unable to go to the CT image because they are unstable. So most of the patients had in this study chest X-ray, and this increases probably the amount of misclassification in both groups of patients under personalized treatment and non-personalized treatment. And the effect of treating a patient with a wrong intervention because you did a wrong classification is that we reduce the probability of survival. Here, the dotted lines shows patients with a misclassification and misaligned treatment, despite the focal or non-focal disease. And the continuous lines shows the corrected classification and the corrected treatment. And clearly there is a difference between those two. And in a per protocol analysis, they found that patients with the personalized approach had better survival compared to the control group. So how can we use EIT to optimize those findings? One approach is understanding the disease, right? So based on this background from the French study, we start using EIT to phenotype lung morphofunction, classifying hypoxemic patients as with focal or non-focal disease. And here we have one example of a patient with non-focal disease based on EIT. That means a normal ventilation distribution among the lung quadrants. And we can have different possibilities for focal disease. For instance, patients with bilateral dorsal hypoventilation a patient with only one quadrant with hypoventilation or the entire lung being hypoventilated. So in this approach, we are trying to, in addition to separate patients with focal and non-focal disease, we are differentiating the focal group as bilateral focal and unilateral focals. We have some data supporting this classification. Here we have some numbers comparing the phenotype using CT and EIT for focal and non-focal, and as you can see, the error between the methods is minimal. And in a sample of healthy subjects, both EIT and CT agree saying that there is no focal disease, that this is what we should expect, right? This is new information that I'm sharing with you. We just tested how stable is this classification using EIT, and following patients up to 4 hours after the first diagnosis of the motor function imaging, we saw that most of the patients had the same diagnosis before and after this time interval. So more than 89% of the patients had a stable diagnosis. And this is important if we want to have a reliable diagnostic for patients. A little bit about epidemiology. We found that patients with focal disease are more prevalent than non-focal. This database was built with patients with COVID. We have up to 100 patients in this database. And we saw that the phenotype with bilateral dorsal hypoventilation and unilateral dorsal hypoventilation are well predominant here. Comparing with PF ratio, we were able to see that phenotype with bilateral hypoventilation demonstrates lower PF ratio, lower oxygenation, and this is easy to hypothesize that probably because we have more shunt and poor gas exchange. But something interesting, when we use a cutoff of 150 of PF ratio, that is the current status for defining proning or not a patient, we were able to see that these patterns of dorsal lung disease, bilateral or unilateral, correspond to 70% of the patients. So the majority of patients with ARDS due to COVID, we found that they had dorsal issues. And this may explain the results of Dr. Guérin comparing prone and supine patients, suggesting that prone positioning improved survival. For us, this can be one explanation, is because the majority of patients has a biological problem that prone can fix when we change the pleural pressure at the posterior part of the lung. And this is exactly what this study, the live study, tried to do, was trying to use proning positioning as a mandatory treatment for patients with focal lung disease. Okay, so how can we use EIT to optimize this body positioning treatment? Let's take one example. Look at this patient. Look at this chest X-ray. This is a patient with ARDS with a poor PF ratio compliance of 25, PEEP of 8. And we see bilateral infiltrates, low lung compliance, but it's difficult to define if this patient has a disease that is focal or non-focal, right? Take a look on the EIT image. Now we have an EIT of the same patient showing that the posterior left part of the lung seems thicker than the posterior right part of the lung. We have a greater area of hypoventilation in the posterior left part of the lung. Because of that, we decided to use proning positioning. And as we can see here, the posterior part that before in supine was hypoventilated now is well ventilated, and global compliance increased to 45. Now we can explain why the global compliance increased in this patient. It's because we have a patient that could benefit of proning recruiting this posterior part when we change the body positioning. I'm not going to go in details in perfusion assessment, but I would like to show you that EIT can also measure this. In the next month, you have a webinar discussing only perfusion. But this is the same case I was showing before, the ventilation image in supine and prone, and look the perfusion. We have some perfusion in the posterior part of the left lung, but not ventilation at all. And when we change to prone positioning, we have now bilateral good perfusion and bilateral good ventilation. And the pixels in red here shows areas with shunt, and clearly we have a reduction in absolute level of shunt. Another case, now having the CT image makes easy to understand that this patient has a focal disease. The posterior right lung is sicker than the left lung. And if we look at the EIT image, clearly those images are agreeing, right? We have one anatomical image suggesting this impairment, and the EIT functional image is showing that there is no ventilation at the most dorsal part of the right lung. Then we decide to prone this patient, and look what happened. We have the recruitment at the posterior part, but the ventral part is fully recruited, de-aerated. And by the way, this image was collected at the PEEP level for the maximal compliance. So was already optimized the PEEP for this patient. Why this image is interesting is because even knowing if the issue is focal or no focal, and we decide to prone this patient, it's quite impossible to have for every patient in the ICU CT scans before and after body positioning change. And clearly, we lost the ventral part of the lung. If we have this kind of functional image at the bedside, we may think about ways to improve that, or maybe if the amount of lung that was recruited at the posterior part compensate the ventral part, the aeration, we are okay, right? Because we know for some patients, the prone position works as a combination of recruiting new areas and the recruiting the ventral part, and probably the positive effect of increasing the functional size of the lung, increasing the compliance and reducing driving pressure is when we have more recruitment than the recruitment from supine to prone. We know that the effect for some patient is not as expected. Look, this case, we have bilateral hypoventilation due to consolidations in supine. When we change to prone, we have only one posterior part of the lung being recruited, but this other is not opening at all. And the other patient below shows bilateral good response in after prone positioning. We just published this paper comparing the proning effect using EIT. And this image, here we have in blue pixels with improved compliance after pronation, and in red regions with reduced compliance after pronation. As you can see, both patients with poor perforation and ARDS, and clearly the amount of recruited lung is completely different between those two patients. Looking at PV curves, we have also an interesting information. This is the dorsal region PV curve, the volume and PEEP on the x-axis. And for patients with poor response to prone, the dorsal lung looks like the same. There is no major change in compliance and aeration. But when we have patients with this behavior, we have much better compliance at the dorsal part of the lung in prone position compared to supine. And another interesting information that we can extract from this graph is this: to have some improvement in compliance in supine position using PEEP, we must use much more PEEP compared to prone position. So in this case, we can assume that prone position is a cheap way to recruit the lung using less PEEP compared to supine positioning. And then we decide to compare patients with focal and non-focal, the prone positioning effect, dividing this patient according to the morphofunction. And look this interesting result. When we have non-focal patients, the effect in respiratory compliance from supine to prone is the same. But when we have focal patients that would be better responsive to this intervention, we have a significant improvement in compliance after pronation for focal disease. And most interestingly, when we look at the PF ratio, that, by the way, is the current variable that we use at the bedside, right? Is the PF ratio. We can see that in both cases, we improve oxygenation. And we know that up to 80–90% of patients with ARDS improves oxygenation with PF, with prone position, but perforation is not sensitive to distinguish the mechanical part related to recruitment and improving lung function. So clearly, the signal for the mechanical component is here, is when we differentiate patients with focal and non-focal disease. And returning to this distribution of patients with the different phenotypes, I showed you before that patients with only unilateral focal disease were the more predominant patients, up to 40% of these patients with unilateral focal disease. And then we start to think about why not using lateral body positioning to fix this problem, because bilateral seems prone is the unique way to fix it, but for unilateral, maybe lateral positioning is much easier to be applied. We have some data collected in animals suggesting that this is possible. Here we have a CT image in supine, and we can see the air ratio in the right posterior part of this pig. Then we change to left down with this seeker area up, and we can see now an improvement in aeration at this part. And once returned to supine, we have an improvement in function. This approach was tested recently by a colleague from Peru, Colin Rodan, and he applied sequential body positioning in patients with COVID-ARDS to the right and the left side, and he found that respiratory system compliance and regional mechanic improved after this intervention. Now let's look at the ventilatory settings. How can we use the ventilation image for assessing lung recruitability and PEEP settings? Well, using EIT, this is the simplest way to assess the effect of increasing PEEP. In this image, we have a patient with 10 centimeters of water, and look the heterogeneity in ventilation distribution. Notice that the posterior part, we have more gray areas. We don't have a ventilation. And if we calculate the proportion of ventilation, we see 80% of the tidal volume is moving to the ventral part, and only 20% is moving to the posterior part. Consider that you set 400 milliliters for this patient. This image suggests that 320 is inflating the non-dependent part of the lung, which may cause regional overstretching. Then we decide to increase PEEP and observe the results. The new image suggests that the posterior part is now well ventilated. the hypoventilation seen at PEEP of 10 now was fixed. And please note that the number of the functional pixels had increased, right? And the proportional ventilation distribution now is more balanced between anterior and posterior part. This EIT information agrees with the knowledge that we have about lung recruitability in ERTS. We know that for some patients increasing PEEP, we are able to recruit the dorsal part of the lung. But we know that some patients, even increasing PEEP up to 45, this is an intervention that is unable to recruit. So we have patients with different response. And if you have only the global parameters of the ventilation settings, we can't distinguish if the posterior part of this patient was recruited or not. Let's take one example. Imagine this patient. We have a compliance of 21 under volume control. This is the plateau pressure, PEEP, and the tidal volume. Then we decide the recruitment maneuver, the incremental PEEP trial. We find the PEEP for the maximal compliance, and we set this 15 of PEEP, 26 of plateau pressure, the same tidal volume, and compliance increase. You can believe that this patient responded well, right, to PEEP and feel comfortable with the reduction in driving pressure. But if we look at the CT image at the both levels of PEEP, low and high level of PEEP, we can see that the posterior part of the lung is still deaerated. The PEEP of 15 may be recruited more the left lung, but not the posterior right lung. This is a nice way to see the anatomical effect of the PEEP. Using EIT, we can see that at the same level of PEEP for the same patient, the posterior right is agreeing with the CT. There is no major change in the posterior right part of the lung. Only the left lung now looks bigger and more ventilated. So in this case, if I have this image from this patient, I would say that PEEP of 15 in supine position is probably not the best approach, and I must try prone positioning and repeating the procedures to check if prone positioning would improve even more this part that PEEP of 15 was unable to fix it. So we can use this image at the bedside to better understand the response of PEEP and better define the next treatment. Another way to monitoring recruitability is looking at the tidal change in ventilation and the tidal change in the end expiratory lung volume that we can collect it using EIT. Here we have one example with incremental and decremental PEEP with a fixed driving pressure, and we can see clearly when PEEP is increased, we have an improvement in end expiratory lung volume. That this can occur due to recruitment or just because we are overinflating the lung. That when we start to reduce PEEP and compare the aeration at the same level of PEEP, we can see that in this case, the end expiratory lung volume now is much higher than before. So this approach is very useful when we want to match the end expiratory lung volume before and after removing the PEEP effect. We are seeing here the recruitment that was produced by PEEP increasing in this patient. And another information, we can see that the tidal change now is bigger than before. So we have two physiological phenomena showing that aeration and tidal change increase, and this means recruitment. And looking the EIT image, we can see a posterior lung recruitment for this case. And an additional information, we can believe in the change in the end expiratory lung volume assessed by EIT. This is a recent paper we published showing that EIT and CT agrees with this change in lung aeration. So this is a easy way to monitoring at the bedside the change in aeration as well. EIT can be used to assess recruitability using the assessment of lung collapse, and this is not going to be discussed today, but the EIT method to calculate lung collapse is based on the ventilation image. So that's why I'm showing this paper. They use a sophisticated approach developed by Dr. Costa, that uses the tidal change in ventilation divided by the driving pressure. That means the regional change in compliance using EIT to estimate the collapse. And in this paper, the authors use this method to stratify patients as low recruitability, medium, and high recruitability using a cutoff of higher than 40% of changing in collapse during a decremental PEEP trial. And interestingly, they found that patients with high recruitability may need more PEEP compared to patients with low recruitability. And more interesting, using the physiology that EIT measures, we can see that for the same absolute level of PEEP, we produce much more overdistension when we have a patient with low recruitability compared to a patient with high recruitability. And this distinction of patients with high recruitability and low recruitability affects the effect of driving pressure. We can have a more significant reduction in driving pressure when we decide to recruit patients that are recruitable, right? And to finish my presentation, let's see how EIT can allow us a safer transition from the control to the spontaneous ventilation and the weaning as well. Few years ago, Dr. Yoshida described in this interesting paper, the pendelluft phenomenon. This is a phenomenon that was well described during the 70s by the greatest physiologists, showing that we can have in the same patients air moving from one side to the other based on change in regional compliance and regional resistance. This was quite common in patients with severe COPD and asthma. But in 2013, that was the first time that we were aware that this could happen in patients under mechanical ventilation with ARDS. And in this paper, Dr. Yoshida and colleagues showed that we may have different dynamics in ventilation distribution when we have a strong inspiratory effort. Let's see first this graph on the right side. Here we have a patient under controlled mechanical ventilation without any effort. And once we have a positive flow, we can see the most anterior part of the lung, the zone 1, and the most dorsal part of the lung, the zone 4, being inflated at the same time. But when we have a strong inspiratory effort, we have the flow moving up, the air moving from the ventilator to the patient, but we have the most ventral and the most dorsal move in asynchronous behavior. We have the ventral part being deflated, the dorsal part inflated, and the result of that pendelluft effect is we have an overstretching at the most posterior part of the lung. And why? Because we have the tidal volume delivered from the ventilator, plus the volume that changed from one part of the lung to the other part of the lung. So this may induce lung injury. This is one example showing how different is the pattern when we have controlled ventilation with simultaneous lung inflection and when we have strong inspiratory effort during assisted mechanical ventilation. And recently in physiological study, we compared the pendelluft with PET scan, and we found that the area, the intensity of pendelluft agrees with more inflammation detected by PET scan. We have also data supporting in patients with ARDS. Here we have a recent paper published by Dr. Cornejo comparing pendelluft with inflammatory biomarkers. And we can see that when we have patients with a huge amount of pendelluft, there is some relationship with interleukin 18, 8, and caspase-1, suggesting this relationship. But more interestingly, we found that the global parameters that we measure at the bedside, such as tidal volume, delta transpulmonary driving pressure, and esophageal pressure, are not well correlated with the biological biomarkers. And the explanation for these differences of global parameters and the pendelluft is because we learned that pendelluft depends on a regional effect with higher drop in pleural pressure at the posterior part of the lung. So pendelluft is a regional phenomenon, and we are able to see the effect on inflammation only when we measure the regional level. When we have global parameters, we may not see if the patient is under risk of more PSILI or not. Considering now pendelluft and weaning, this is a nice paper by the group of Giacomo Bellani. The first author is Andrea Capadoro, where the authors assessed patients with EIT, patients that were ready to wean, were patients that had the resolution of the ARDS cause with low PEEP, low FiO2, light sedation, but they failure. And what they found? They found that the amount of pendelluft was higher in some patients, and the amount of pendelluft increased when pressure support was reduced. And for some patients, we know when we reduce pressure support, they feel the necessity to increase the inspiratory effort, and the amount of inspiratory effort that this drop in pressure support may produce may justify the increase in pendelluft in the sample of patient. And interestingly, the authors of this study found that patients with high pendelluft presented high end expiratory CO2. And there is a very interesting rationale in this paper that is when we have a patient during the weaning process that present pendelluft, and consequently the CO2 increases because we have gas that we can consider a non-efficient movement of gas. We have a gas with high levels, high pressure of CO2 and low level of oxygen moving from one side to the other. And this makes the ventilatory system more inefficient, and we may increase the respiratory workload. So this is one example how pendelluft may help us to understand why some patients are failing the weaning process. And to finish this presentation, one interesting paper using the change in lung aeration, the change in end expiratory lung volume to assess weaning. In this paper, the authors assessed patients with endotracheal tube, were not patients with tracheostomy, were patients with endotracheal tube during the weaning process, and they assessed patient under pressure support SBT and T-tube SBT. And interestingly, they were able to see a difference in the end expiratory lung volume in patients only with the T-tube weaning process. And the most interesting information that we have from this paper is the trend of end expiratory lung volume in time. Here we can see that from the disconnection of the ventilation to the starting the first minute of the T-tube SBT, we can see a drop in the end expiratory lung volume. But this drop is not that important. And why? This first drop is not important because we may have a drop that is depending on the respiratory system compliance. If we have a patient with higher compliance and another patient with a lower compliance, the patient with higher compliance for the same expiratory driving pressure will show a higher reduction in end expiratory lung volume. But the most important physiological data that we can see here is the trending after the first minutes. Clearly, for the patients with success, they have a first drop, but no more dropping in lung aeration. But in contrast, we have patients with continuous reduction in end expiratory lung volume, and this is represented by the patients with Weaning failure. Probably the explanation for this behavior is a progressive increase in atelectasis, a progressive reduction in lung aeration during the process. Okay, so to finish the take-home points, we believe that the use of EIT, the ventilation imaging used by EIT, that is a simple way to assess the patient, can be used to differentiate lung morphine function to distinguish patients with focal and non-focal disease. And this may represent an important step toward bringing personalized medicine in the ICU. And I hope I show you some examples how this simple method, the ventilation image, may help us to optimize the respiratory support better, defining the treatment from the intubation to the weaning process. So I would like to thank you for your attention and thank you for to be here today. And I'm happy to answer questions if you have. Thank you.
Thank you very much, Caio, for such insightful presentation. And before we wrap up the discussion, I would like to hear from our participants now. So please, if you have any question, I would ask you to drop them in the chat. So we will try to address all of them in a short time that we have here. So please feel free to ask any question related to the cases discussed today or about applications of electrical impedance tomography. And we are here now to clarify and deepen a little bit more the conversation. Okay, no questions. Okay, so we have one question here for Dr. Alfred Wong from Hong Kong. So should we use volume control or pressure control when assessing recruitment with the EIT?
Oh, that's a great question. So I would say if you are monitoring the airway pressure, you can use both of the modes. But if you are not using the pneumotech to measuring airway pressure, to measuring driving pressure, the best way is fixing the driving pressure using pressure control, because we can believe that all the changes in the tidal EIT plethysmogram are related to improvement in compliance or reduction in compliance because the driving pressure is fixed. So it depends. Here, usually we have always the airway pressure monitoring, and we prefer using volume control just to avoid tidal recruitment. So we may have a better assessment of recruitable lung, not including the tidal recruitment effect.
Okay, thank you very much. Any other questions here? Okay, how to assess the magnitude of negative effect of pendelluft at the bedside?
Yeah, that's a great question. So what we know now is that when the pendelluft, the magnitude of pendelluft is higher than 25%, we have a good signal suggesting change in lung inflammation. So to measure these, we need to compare the waveforms. Comparing the waveforms sometimes is not that easy to have a quantitative assessment of that. A qualitative assessment is quite easy, right? We see the opposite phase of the lung inflection. To quantify this, currently what we do, we extract the data and we process in an offline analysis the amount of pendelluft that we have. But I'm aware that there is a tool that was validated and is going to be released in a short period of time that do this automatically. So I believe this is going to make our life much easier to quantify the amount, not just having the qualitative diagnosis of pendelluft, but also quantifying. Because, by the way, I believe that I have some pendelluft here right now, but I'm not going to die, right, because of that. So I believe that the pendelluft is a matter of a J curve. If we have some, is good. If we don't have any, means that we are not breathing at all. But if we have a huge amount of pendelluft, then this can be harmful. So I fully agree that we need to quantify the magnitude of that to be sure to differentiate patients with acceptable level of pendelluft and danger level of pendelluft.
Oh, another question here. This is a good one. If it's lateral positioning recruitment, it's lateral recruitment the future?
Yeah, thanks for the question, Elmer. I believe so. And I believe that in the future, we are going to, to use much more lateral position because will be feasible to differentiate patients more prone to benefit of prone positioning and lateral positioning. Once we are able to identify bilateral and unilateral, we can distinguish better the patients, right? And some physiological data that we are collecting and publishing as well suggests that body positioning in general is a cheaper way, is the cheapest way to recruit lung. Sometimes we need much more PEEP and hemodynamic impairments to recruit parts of the lung in a patient in supine positioning. And we are learning that lateral positioning and prone positioning as well are much easier to provide recruitment with low cost in pressure and low cost in hemodynamic as well.
Okay, thank you very much. So thank you. If there is there any other question here? Okay, thank you, Elmer. So can we, another question here, can we evaluate ventilation asynchrony with EIT? With EIT, how can we assess it?
Yeah, that's a great question. Thank you, Elsie. I hope I'm pronouncing correctly. So most of the desynchronies that we have at the bedside are based on global parameters, right? Are based on flow, pressure, and volume waveforms. And pendelluft is one example. There is no way to measure these when we're using the ventilator, because we have a regional dysynchrony, intrapulmonary dysynchrony. So pendelluft is a important dysynchrony that only EIT can help us with that. I like as well to monitoring patients with double triggering and reverse triggering using EIT, because most of the ventilators, when you have a double triggering, when you have a double cycling, one cycle plus the other, most of the ventilators force the volume monitoring to 0 to start the new inflation. And a non-expert may think that everything is okay because the volume, the maximum inspiratory volume seems the same, right? But when we have the change in EIT impedance, the plethysmogram, we can see for patients with double cycling, the breath stacking, we can see the amount of overstretching that certain dysynchronies are producing. So I believe that this adds to our knowledge if the asynchrony is bad or not. And just to give you the last example, there are at least 2-3 papers showing that reverse triggering, when we have a weak effort, that reverse triggering is not that bad because we are keeping the muscles working, being acting. But when we have a strong reverse triggering, we may damage the lung. We may damage the muscles, the muscles, because we have a strong eccentric contraction. Okay, so how can we add EIT in that perspective? Because now we know low effort, we have diaphragmatic dysfunction. High effort, we may damage and increase inflammation of the muscles. If we have the plethysmogram, and the plethysmogram, the tidal change in the waveform is well correlated with the intensity of effort, we may see if the plethysmogram is changing too much or not. And we may accept some level of reverse triggering that are not overstretching the lung and avoiding reverse triggering even without the second cycle if we have strong regional overstretching. Because we know that reverse triggering with a strong inspiratory effort causes pendelluft. So we are back to the pendelluft again.
Kyle, I think that we can go for the last question here from Serge Hines. Is EIT ventilation distribution measuring reliable after changing body positioning due to changes in intrathoracic fluids and changes on the pressure of the electrodes?
Yeah, that's a great question. That's a great question. So we know that when we change too much the chest wall anatomy, we may change the numbers that are collected. And why? Because the EIT measures are based on a priori image of the respiratory chest wall, right? The respiratory system. So if we change too much, if we compress, we induce some deformation in the chest wall, all devices may believe that the electrode is in some position that currently is not. So we may have some change in the reconstruction image based on that. So what we do to have comparable numbers, we try to do this kind of intervention, not changing too much the patient. For instance, when we do lateralization, we don't do 90 degrees because the chest wall looks like a sandwich, right? We do like 30 degrees inclination, trying to keep the chest wall more homogeneous, avoiding the change in the shape. From supine to prone, we were able to compare, and this change in the chest wall anatomy was not that enough to reduce the agreement with CT. So for this, I'm okay. And the last part of your question about the fluids, this is a limitation, and this is a limitation when we are looking at the trend and end expiratory lung volume. For the tidal change, for the tidal ventilation, this is not a problem at all. But if you are looking the trend and end expiratory lung volume in time to see if the lung is being better aerated or less aerated, you must considering stopping the infusions, because we know when we increase the fluids in the thoracic in the thorax of the patient, intrathoracic fluid, we have easier electrical pathway, right? So we have a reduction in resistance, and then we may conclude that the lung is less aerated, but this conclusion is going to be wrong because it's just because we have more fluid. So so because of that, I suggest for everyone, for instance, if you are monitoring a patient during the weaning phase and you are interested to check the change in expiratory lung volume, stop or reduce as much as you can the infusions. Otherwise, you are going to see a fixed trend in the end expiratory lung volume.
So thank you very much again, Caio, for your presence.
My
Thank you
pleasure.
for this enlightening presentation. A big thank to everyone that is present here today that participated in the webinar. And just before we close, I just would like to briefly highlight the main significance of ventilation distribution monitoring with electrical impedance tomography, because as we've seen here in our presentation, EIT can provide us the real-time and non-invasive insights on how the air is being distributed across the lungs, and can help us to make more informed decisions during the critical moments, from the institution of the mechanical ventilation until the liberation of the patient, giving us a better understanding on the lung function of the patient. And by understanding these regional ventilation patterns, we can better prevent some complications as well, such as decreasing ventilator-induced lung injuries, tailored and individualized treatment according to the real needs of the patient. And of course, we are biased to talk about it, but EIT is an invaluable tool for advancing the care of the patients in the ICUs worldwide. And I hope that this session gave to all of you useful insights on how EIT can be applied in the clinical practice. Thank you, everyone, for your time. Thank you, everyone, for the questions, for the participation. And as Caio mentioned, in October, we will have a second webinar that will address now the role of EIT in measuring perfusion at the bedside and how we can better understand the distribution of ventilation and the distribution of perfusion, and how the information of both, a balance in between ventilation and perfusion, can be targeted according to the information of EIT. So I will share with all of you that were present here today the invitation before we release this webinar, so you know it, all of you will know it firsthand. This webinar is being recorded. We will share this webinar in our online platform, that is www.timpelacademy.com. So I will send the information to all of you as soon as the webinar is available to be accessed online. And thank you, everyone, again, and hope to see you soon in our next webinar. Thank you and have a good night.
Bye.